and without reduced LV ejection fraction. Dr. Maragiannis is the Director of Cardiovascular MRI Laboratory at the General Military Hospital in Athens. Dr. Maragiannis, it is a great pleasure having you here. And please proceed with your presentation.
Thank you very much for your kind invitation and the initial introduction. Yes, I made a small comment about Mavacamten before I start my talk. There are some small cohorts actually that they have seen LV mass reduction and LA volume reduction and maybe LVF reduction in this cohort. I think it's a small Chinese study in 2025 that I've seen that paper. Regarding the LGE, they saw a little bit of a reduction, but in some other studies that I've seen also, they didn't see that trend. So we need larger studies and waiting for more years because that small study was about for 30 weeks only. So we have to wait for more results about Mavacamten and their results. So now I'm going to move to my talk. I have no disclosures. We're going to talk about a very interesting subject. It's about how to use CMR in heart failure patients. Currently, treatment decisions are guided by LV ejection fraction. By the initial classification from the guidelines, we now have patients with heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and patients with heart failure and preserved ejection fraction. And we all know that heart failure is the final common pathway of many cardiomyopathies. And of course, myocardial fibrosis is a key mechanism. Heart failure patients with preserved and reduced ejection fraction experience similar rates of mortality and morbidity, as we can see in that nice paper. However, echocardiography is the primary imaging modality for heart failure assessment. For ventricular systolic and diastolic function assessment, we know that we can calculate LV strain and LA strain, and of course we can assess valvular function with echocardiography. However, there are times, like on the images that I'm showing on the right, that the images are suboptimal. We have a limited field of view. So in that patients, we cannot assess very well the anterior wall with echocardiography, while on the right, you can see very nicely the hypertrophied anterior wall with CMR in a patient with HCM. Regarding the guidelines from ESC and AHA, CMR is indicated for the assessment of LV ejection fraction in patients with, for whom echocardiography is inadequate. And CMR can be also recommended in the diagnosis or management of patients with heart failure or cardiomyopathy with a class 2A indication. While use CMR, we know that CMR provides us accurate measurements of ventricular volumes and ventricular function with highly reproducible results. Images have excellent signal-to-noise ratio, excellent contrast between myocardium and blood pool, images with high spatial and temporal resolution. In addition, we can quantify flow accurately. With LGE sequences, we can assess replacement fibrosis. With T1, T2, and T2 star mapping, we can assess intracellular and extracellular changes of myocardial tissue. We can assess also interstitial expansion with the marker called the ECV, and we can assess also edema with T2 mapping and STIR sequences. Going back to the patient with heart failure, first of all, we have to define etiology, we have to determine the prognosis, and when we have all this information, we have to guide our management. Should we, for example, revascularize our patient? Should we go for ICD implantation, or should we stay on medical treatment only? Here, in that old study from 2000, we can see underlying causes for heart failure, like idiopathic cardiomyopathy, cardiomyopathy due to ischemic heart disease, or other causes. And you can see that with all these different causes of heart failure, we have different outcomes, and the survival rates are different regarding the etiology. We all know that most of the patients, it's a very common cause for heart failure to have a patient with coronary artery disease. So in this very interesting study from 2022 have real world data. Only 35% with only 35% of patients were screened for coronary artery disease with different modalities, as you can see: angiography, stress ECG, nuclear, stress echo, MRI, cardiac CT. And some of these patients were revascularized, only 9% if I can recall from the study. And what is very interesting, you can see the underutilization of CMR in that patient cohort, which is patients with heart failure. When I'm looking to my patients with heart failure, the first thing I look at the morphology. I'm going to my cine images and look at the morphology. For example, do I see a hypertrophic morphology? Do I see a dilating morphology? Or do I see an arrhythmic morphology? So this is very interesting because, first of all, we get a phenotype of disease, and then we can move on with our CMR to the LZ distribution and the LZ patterns. And following that, we can also calculate T1 values and ECV values to have more information from our CMR. Regarding LZ patterns, we all know we have the ischemic and non-ischemic patterns. So CAD scar is usually subendocardial and or transmural, while non-CAD scar is mid-wall hyperenhancement, epicardial hyperenhancement, or global endocardial hyperenhancement in different kind of non-ischemic cardiomyopathies. So if we go to coronary artery disease patients, as we can see here, a patient with dyskinesis of the apex and a transmural infarct at the LG images, LG can identify reversible and irreversible myocardial injury. And we know from that study from 2000 that almost 2% of segments with scar beyond 75% of the LV wall exhibited functional recovery, while 78% of dysfunctional segments without LG showed contractile improvements. Is it important to have an MRI? Yes, of course it is, because there are many studies that we will see an unrecognized myocardial infarction, and we know that patients with recognized or unrecognized myocardial infarctions have almost the same prognosis compared to patients that have no myocardial infarction on the CMR. Of course, using T1 mapping and ECV values, we know that in patients with coronary artery disease, non-infarcted myocardium has elevated T1 values, native values, and this is very important in the prediction of outcome. A very nice study also showed us that in patients with coronary artery disease that were referred for a clinical MRI, non-ischemic cardiomyopathy or dual cardiomyopathy was identified in 1 out of 6 patients, and these kind of patients have also a worse long-term prognosis. Moving on to non-ischemic cardiomyopathies, and of course the most common one is hypertrophic cardiomyopathy. We know that LZ is typically subendocardial, predominantly in the areas of hypertrophy and at the septal incisure sites. And as you heard in the previous talk, in patients with extensive LGE, the risk of adverse outcomes increases with percentage increase in LG extent. Of course, in these patients, scar progression is very important to know because it's correlated with adverse outcomes. Here I will show you one example on figure A of a 50-year-old man with HCM. He had a LV ejection fraction of 60% and LT extents of 4.1% of LV mass and wall thickness of 30 millimeters at the basal septum. And next to it on the right is the study 10 years later. He developed a dilatation of the LV cavity. We have an LV ejection fraction reduction to 46%, a thinning of the myocardium to a thickness of 21 millimeters, and now he has a diffusive extensive LGE of almost 32% of the LV mass, and he had an ICD implantation following that study. T1 mapping in HCM is very important too. As you can see in the very nice study, that patients with, for example, apical HCM have higher values in the apex of ECV and the native T1, as you can see, compared to the healthy participants. And the same stands for patients with septal HCM for the basal and mid-wall septum. Moving on to cardiac amyloidosis, which is an infiltrative disease with a hypertrophic phenotype. It's characterized that disease with extracellular accumulation of amyloid fibrils, and there is edema, inflammation, together with myocyte hypertrophy. And we know that most common LG pattern, as you can see on the third column, is the global transmural or subendocardial LG with high native T1 and ECV values. LG, T1 mapping, and ECV are helpful in the assessment of the prognosis in cardiac amyloidosis, and ECV has a better, actually, diagnostic and prognostic performance than LG alone. Moving on to dialytic cardiomyopathy, here we know that replacement myocardial fibrosis occurs typically in the mid-wall in approximately 1/3 of patients, and is independently associated with an increased risk of mortality and the heart failure morbidity. That LG also determines the likelihood of LV's reverse remodeling in response to pharmacological therapy. ECV characterizes in those patients the risk of heart failure outcomes, incremental to LGE, and in patients with DCM and mild to moderate LV systolic impairment, who do not meet conventional criteria for an ICD, the presence of mid-wall LG identifies a subgroup of high risk for sudden cardiac death. And we have this very nice study with patients that do not have a scar and patients that have a scar and LV ejection fraction less than 35% and moderate to severe heart failure. ICD plantation was only associated with a survival benefit only in patients that had an LV scar. Other non-ischemic cardiomyopathies is, for example, ARVC. We have the Padua criteria, as you heard in the previous talk. And in these patients, we have the presence of both qualitative findings, like RV regional akinesia, dyskinesia, desynchronous contraction, or quantitative criteria, decreased RV ejection fraction, or increased indexed RV end-diastolic volume. Inflammatory diseases like myocarditis, to get a diagnosis of acute myocarditis, we need a T2-based marker for myocardial edema, like T2 mapping or a STIR sequence, and T1-based marker for associated myocardial injury, such as native T1 mapping, LGE, or ECV. Sarcoidosis, cardiac involvement is associated with worse prognosis and is characterized as a disease with non-necrotic inflammatory granulomas. On the left, you can see a patient on figure 1A, and you can see on the basal LG on the inferior wall, and you can see active inflammation with PET on the figure C, which is the same patient. While on figure B, you can see a patient with LG on the septum, and you don't see active inflammation on figure D, which is the same patient with cardiac PET. On the right, you can see a patient without LG, whereas PET was showing active inflammation on the same patient on the lateral wall on figure B. And below, you can see higher values in T1 and T2 mapping in the same area with CMR. We all know that the prognostic value of myocardial scar with LG on CMR in patients with cardiac sarcoidosis, and it's very important to know if there is LG or not for prognostic purposes. We're moving on to Takotsubo disease. In Takotsubo, of course, we can identify the regional wall motion abnormality with the CNS. Usually, they don't have scar, usually 9% of the patients may have some scar. In this patient on the third row, you don't see any scar actually, while you see on the middle row edema in figure C, which is the most commonly seen in almost 81% of patients with Takotsubo disease. Moving on to LV&C cardiomyopathy, we know that the CMR has increased sensitivity in the detection of myocardial tuberculations. We use the criteria where non-compacted to compacted lasers greater than 2.3 is considered diagnostic of myocardial non-compaction. And we can see at times areas of trabecular or cardial LG can appreciated in these areas. Moving on till now, we talked about the morphology in CNS. Then we moved on to the LG patterns, and then we used T1 mapping and ECV in order to evaluate our heart failure patient. But now there are also some alternative methods that we can use to evaluate a patient with heart failure. And for example, feature tracking CMR GLS can predict CV death and hospitalization in patients with heart failure and preserved ejection fraction. There are other markers like LA strain, and we know that LA strain in patients with heart failure and preserved ejection fraction is associated with increased mortality. We have also LA ejection fraction, another marker which can be correlated with LVEDP, and we know that the reduced LA ejection fraction correlates with LV dysfunction. In some centers, they use 40 flow sequences in order to evaluate diastolic dysfunction because they can evaluate diastolic filling patterns. They can evaluate pulmonary vein velocities with 40 flow sequences, and they can quantify duration of non-laminar flow in the pulmonary artery as a measure of pulmonary hypertension. Some new approaches with CMR in some centers, but it's not widely available, is some other techniques like diffusion tensor imaging, where it's a measure to detect the average myocyte orientation. Another technique called CMR elastography, in which they can detect myocardial stiffness. And another technique called lung MRI, they calculate lung water density as a surrogate of pulmonary congestion. Below, I'm showing you an example of controls of patients with preserved ejection fraction and patients with cardiac amyloidosis, where you can see with red color the lung water density increased in those patients. Another technique called magnetic resonance spectroscopy has been also used to evaluate myocardial energetics. So, is it CMR for all? There is a very nice study. It was called Outsmart Heart Failure Study, where they had two arms. They used echocardiography plus routine CMR in the one arm, and the other arm was echocardiography plus selective CMR in the other arm. So in that study, they show that similar proportion. They found that they had a similar proportion of specific heart failure causes at clinical follow-up. So the study revealed that CMR should not be used routinely for the diagnosis of non-ischemic heart disease. Following that, we can say that CMR imaging provides very valuable information about the patterns of fibrosis, the etiology of heart failure, the recovery of ventricular function, and information about disease prognosis. And tissue characterization can help us guide our management of heart failure patients. Thank you very much.
Thank you very much, Dr. Maragiannis, for the very nice talk, which was an excellent review on non-ischemic and ischemic heart failure. Do we have any issues to discuss, Stamatis, after this excellent presentation?
Very nice overview, actually, in the wide range of heart failure. Dr. Maragiannis. I've got just two comments. One is that in HFpEF, with preserved ejection fraction, right ventricular function is extremely important. And as you pointed out, CMR facilitates accurate right ventricular volumetric analysis. It's not very often, we don't very often see right ventricular dysfunction in HFpEF, but in 20-30% we see right ventricular dysfunction. And it's very important to detect this sort of dysfunction for both therapeutic and prognostic reasons. And the second comment is that CMR in HFpEF enables us to examine the effects of therapies. Let's say in the SUMMIT trial with the GLP-1 receptor agonist tirzepatide in obese-related HFpEF, CMR demonstrated reduced left ventricular mass and paracardial adipose tissue. And left ventricular also reduced left ventricular LA volume and strain. So I think it's very important also to follow up patients after treatment in HFpEF.
Yes, I totally agree with your comments, especially for the RV ejection fraction is very important. It is a marker that we can accurately measure with CMR. And it's not only for the general population of heart failure and preserved VF. Even if you go back to some specific etiologies, like, for example, sarcoidosis, RV ejection fraction, for example, is extremely important as a marker of prognosis besides LGE and besides other markers. Or the same stands for ERVC and other actually causes of heart failure with preserved VF. So it's very, very important, as I told you from the beginning, to individualize also our treatment because going back to CMR, you will see we get morphology, we get LG patterns, we get numbers from T1 values, and we put everything all together with the volumetrics from LVEF, RVEF, will have a comprehensive image of our patients, and we can guide our treatment options. Yeah. But RVEF in most of the diseases, even valvular diseases, is extremely important.
That's right. Can I make another comment, Michalis and Sophia, before we...
Sophie, we would like to comment on this.
Yes, sorry,
yes,
Sophia.
I thank you so much. Congratulations for the talk. I agree with all this, but I like also to mention the importance of native T1 mapping at TCV. You have to keep in mind that these indices are not stable as LGE. If you give a treatment to the patient, you can see a rapid changes in these parameters. So before, more than in HFrEF, in HFpEF, it's very important to perform CMR because we have an index which is independent from the low overload, from the volume overload or any pressure overload, which is independent and is due only to the situation of the myocardium. So it's a very important information and a very good guide of the potential therapy we give to our patients.
Mm-hmm.
Yes, I totally agree about T1 mapping and even T2 mapping too, because we usually talk about T1 mapping, but sometimes we forget about T2 mapping. For example, T2 mapping is very useful for myocarditis cases that you can see T2 mapping, the values will go lower after some months. So that helps us, for example, understand that the disease is healed now.
It's very important. However, we don't know many things about it, and this is the reason that many investigators overlooked T2 mapping. However, it is very important in many cases in genetic diseases, in hypertrophy, in heart failure, HFpEF or HFrEF, in myocarditis, in Takotsubo, in some phenotypes of cardiomyopathies. So we have to keep it always in mind, but we lack of studies, and we have to work to this direction. Also in athletes, it's very important. We know there is a late editorial about the paradox of T2 mapping increase in athletes. So it is a very important parameter when we evaluate cardiac patients.
Mm-hmm. My comment, Sophia and Michalis and Dr. Maragiannis, is in our small but very important population, Sophia knows very well, post heart transplantation with respect to the term non-invasive biopsy. I mean, progressively over the last few years, but I hope it's going to be very important diagnostic tool in the future. CMR, we're expecting to enable us to reduce the number of endomyocardial biopsies.
Yeah.
And not only that, but might also enable us to diagnose something very difficult and very ominous post-transplantation. The antibody-mediated rejection. We had three, I remember, I can recall 3 patients with, I would say, negative biopsy for AMR, but with CMR, with ring-like pattern and edema, and we treat them as antibody-mediated rejection despite the negative biopsy result. So I think it's an increasing interest, and I hope we will see in the near future to replace biopsy post-heart transplantation, either for diagnostic or for therapeutic reasons.
I can add something to this. We evaluated a population with autoantibodies, although they didn't have any other symptom. And it was not possible to identify a pure rheumatologic diagnosis. And in the majority of them, we identified the presence of myocardial inflammation. And we gave them treatment. In some of them, we have follow-up, we found improvement. So the presence of autoantibodies, whatever the reason and whatever the background, it's important to check in a different way using CMR. I mean, these patients and make relevant conclusions.
Okay, it's time.
Yeah, I think it's time. Thank you so much for your participation and active questions and your knowledge you brought in this meeting.
Thank you, Sophia, for offering us this sort of opportunity. And for me, it's a great pleasure to see also Michael.
Yes. Yeah, good opportunity to meet each other. Yeah,
but it's better to see him here in
everywhere.
His origins.
Okay. Thank you very much. It's also a great pleasure and honor for me participating to this excellent CMR, FNCMR session. And it is really great success, which is presenting year by year the substantial progress that is ongoing in CMR studies in various fields of cardiology. Congratulations from my part, I am rather a biopsy pioneer of cardiomyopathies, and have to admit that CMR has taken over the scene. It's also summarized in the current ESC guidelines on myocardial and pericardial diseases released August this year. And congratulations to the CMR scene, which is very vivid, which is very effective. And my question is, will we have the availability of CMR to really address all these needs, diagnostic needs associated also with treatment and prognostication of the various myocardial diseases? We need definitely more availability of CMR. I can tell you that CMR availability in Berlin, which is the capital of Germany, is not enough to address all these issues that are coming up. and all the evidence that has been brought up. And I think that this shortness of availability is also valid for other countries and other cities.
Yeah, that's true. We have all the tools widely available. That's true.
Thank you very much. I would like to thank all the speakers, to thank Sophia.